All right, good afternoon, everybody. My name is Garrett Schmidt, and welcome to the eMed Apps Roundtable discussion, which is on the same theme of ACOs of the future, team-based care reimagined. This is kind of a follow-on to a webinar that was hosted several days ago, but you don't have to have attended the webinar in order to participate in today's discussion. I think there's going to be a lot of great things and topics covered, and you can certainly go back and watch that recording a little bit later. A few items of note before we get started. This is a little bit different of a format than other webinars you may have attended, because we want to get a little bit more interactive than maybe what you've experienced before. So we're not going to have a Q&A session at the end like we normally would. We're actually going to be kind of doing that throughout. So this is going to be very interactive. So what I'm going to do is I'm actually going to unmute everybody, which all that means is that's going to give you the ability to unmute yourselves. And so if you would like to participate in the discussion, what you'll want to do is raise your hand. And on your attendee module, you should see a little hand that you can raise. So if you have a question and you'd like to participate or ask, feel free to do that at any time, so you don't have to wait till the end. And we would love to hear from you, and that's what today is all about. Afterwards, this is going to be recorded, so keep that in mind, and you can go back and watch it later. And we will go from there. Now, if you are a little shy or would like to not do the audio version, you can certainly submit a question via the question module as well. So you don't have to do the audio, but I think it would be fun to be able to hear your voice as well. So, but either way, we'll get to those questions today. Without further ado, I'm going to hand it over to Jeanette Kibasek, who's the Business Development Manager of eMed Apps, and she's going to introduce our moderators for today. And then I'm going to drop off, and you'll see me again at the end, and I'll do some closing. All right, guys. Welcome, Jeanette.
Thanks so much, Garrett. And of course, there's beeping. I am so sorry, everyone. So thank you so much for joining us, everyone. Again, let me introduce Vic Shashadri and Ed Worthington. Vic is from eMed Apps, and he is our VP of product development. And let's see, I've known Vic forever, but let me get this all right. He leads all our product development initiative at eMed Apps. He's also chief architect of our care connectivity platform, and he's been our lead architect on interoperability projects with various clients, including IPAs, ACOs, payers, and HIEs. And with his extensive experience and knowledge, he's developed some really unique and excellent products. And so with that, let me introduce Ed, who is from Northern Physicians Organization. He's the director of IT, and he spearheaded their successful health information exchange, interoperability initiatives, and security efforts. Prior to his tenure at MPO, he spent 9 years working in a variety of capacities at a regional health system. And we are very excited to have you all here. You've got two great experts here that have really done some creative things in terms of being able to share data across multiple organizations, and with them each being on different platforms. And so we're hoping that you really challenge them with questions and participate in the program. That being said, this is kind of like improv roundtable. So with the new normal, everybody being virtual, we'll probably hear cats meowing and dogs barking, maybe a couple of doorbells, but we don't want that to intimidate anyone. We're hoping that you will unmute and join the conversation. If you're more comfortable typing in a question or a response, we're happy to read that as well. So however you're comfortable, please participate. And with that, I'm gonna just get us started off with a question. And maybe let's do a practice. Can everybody raise their hand so we can make sure that if you have a question, you're able to do that. There should be a little hand symbol And when you click on it, it'll turn green. I don't see any hands going up. Oh,
I see a
there
few
they are.
hands.
There they are. Excellent. Okay, wonderful. And then of course the unmute button as well. So with that, let me throw out a question to everyone and we'll get the conversation started. So let's talk about what is your biggest challenge for you for getting information that's needed at the point of care. We know that that is really very important to getting the right care to the right people at the right time, and can really not only impact the quality of care that's given and medical decisions that are made, but also resources that are used. So would anybody like to unmute and tell us one of your challenges?
Well, mine would be from the hospitals or even the specialists that they see.
And that was Melissa.
Yes, ma'am.
Melissa. And you're with Northland Family Care?
Yes.
And
So
go ahead.
I was just saying, kind of get some more specific information, like from the hospitals. Is it like discharge documentation and like test results, and then just specialists like getting notes back in a timely manner and stuff like that?
Yes. Yes. Discharge, procedures, labs, anything. So when the patient comes, you know, we should have that documentation, but we don't.
Mm-hmm.
And Melissa,
That's
do you work with a group of hospitals? Do your patients, are they seen at multiple locations?
Multiple. They use multiple. But our doctors do round at one of the local ones that a lot of our patients go to. So.
And right now, how do you obtain information on patients when they're seen there?
Some I have access to go into the hospitals and get the information, as some hospitals are pretty tight and don't let a lot of, you know, non-rounding doctors go in there. A lot of fax requests.
Mm-hmm.
Yeah, those certainly.
Yeah, it's very timely. Yeah, it's like you send it and you're waiting, even though you put stat. Even if you call, you know, and say, you know, per the doctor, they're requesting it stat, they'll say, well, you need to put it on a letterhead. So that's time consuming also when the patient's either here or, you know, or you fit the patient in.
Yeah, and that leads to a ton of lost, you know, efficiency, because you're basically having staff that could be doing other things, chasing around paper, and you know, there's not enough information possibly at an appointment to do kind of what you need to do. I think, you know, just to kind of kick it off, you know, some of the things that we've done, and we kind of talked about a little bit on our the first webinar, was that what we did with our pilot community, and they had similar issues where, especially with specialists, they weren't getting a lot of notes back in a timely manner, and not necessarily from their hospital consistently. They had about 3 or 4 hospitals spread across their organization. It was a physician organization, IPA, and an ACO as well. And what we did actually was we connected to their, well, we did 2 things. One, we connected to their health information exchange, so that information was sent passively to the organization. So like admissions notifications, discharge notifications, you know, whether or not the patient was in the ER, OBS. For most of the organizations, I think all of them actually, we also received discharge continuity care documents, which aren't always as complete as the document that you might normally get, because some hospitals I know have policies where it could, you know, take a few days for the doctors to do their final dictation. But at least it gives you kind of a complete picture on, basically what happened during the visit, medications and stuff like that at discharge. Diagnosis changes, what tests they may have done in the hospital, any kind of consults they had with specialists in the hospital. And then likewise with the specialist, it's really a pretty complete visit note. It's just in a slightly different format. So we were able to connect these organizations together. Like I said, the specialists in the community, and the hospitals through the health information exchange. And then we also built kind of a one-off radiology and lab interface with a couple of the hospitals as well, so that the organizations and their constituent practices didn't have to ask for information or hope that it got sent back. It was passively there. So they went, when they were doing their normal visit planning or chart prep, and the information was there. And they also got a heads up, for instance, if the patient was admitted to the hospital, and there was something that could be done to help intervene possibly and prevent an ER visit from becoming an inpatient visit, which is, preferable, for the patient overall, but critical for providers that are in risk-based contracts of some sort, to intervene then as well. I don't know about your geography in general, but do you kind of belong to a health information exchange now, or is there one in your area?
You can speak, Melissa.
Oh, okay, sorry. It was muted. Yeah, we do, like I do, I go in and I can get like our patient census from certain hospitals. I can go in, but like you said, some of the discharges are not complete. Some of the specialists in that we do have like a collaboration agreement that, we exchange info with them so we can get the patients, but still, even if some of our patients go to an outside hospital that we don't know of, that we're not even told, that's hard too, out of state, or, they'll come in for follow-up, but yet we don't have none of that information. So,
Okay. And are you part of like an ACO or an IPA or anything like that?
no, I don't believe so. Well, it's in the process. Go ahead.
Oh no. So I think kind of the first thing is to see if your state has a health information exchange, because I know when I worked at a hospital for a while, we did a similar thing where certain providers had access to the census, the EMR, like it was Cerner, and they could go in and see the census for their patients. But that's time consuming, and it's not always accurate as well too, because it's kind of contingent on the patient providing ideas, or the hospital having it on file. In some situations that just doesn't happen. I remember doing like some research, and we found massive discrepancies in some cases. People who are actually at a family practice and the hospital state they're at. One thing I would really look at is, as a first basic step, if you have a regional or state health information exchange, because kind of one of the core services provided would at least be notifications of hospitalization. And that's something that, I don't know, Vic, it might make sense if we actually show that now, how we set that up in a community that we connected to a state health information exchange, which had data probably over 100 hospitals. But, there were probably, I think, 3 or 4 core hospitals where their patients, 90-some% of their patients went to. But I could show you kind of what we did. They were actually Vic will, and how that helps practices, and some of the start with kind of the notification portion, and then kind of dig a little deeper into the actual, like, what the continuity care documents look like and what kind of data they.
Yeah, absolutely. Okay. So I'm going to go ahead and jump into the application here as a clinical support staff or a care team, care coordinator, I should say. And what I'm presented with is a list of things that should be important to me, right? So one of the things that we tried to work with this pilot group is to provide the information that you need at the time that you need it. So the process that you just talked about having to search for information, faxing for records, things of that nature, to kind of take that out of the mix so that the time these care coordinators and clinical support staff are spending can be on care, right? So they're not looking for data, but they're using the data to make decisions. And so what they see is a list of things that are pertinent to them. So things like those notifications that Ed was talking about. So discharges, admits, emergency visits in the community, appointment schedules, so they can see when patients are seeing patients, seeing your practice or other care team providers in your community. And that's sort of the starting point. So they start with this notification information. So, for example, here I've got a admission notification that's come in. So I see some details about that admission. If there's any diagnoses associated with that, I'll be able to see that here as well. So I get a pretty quick picture of what's happening with that admit or that ER situation, and then I can go dig into the data to go look at more details. And the way we do that is we present it in one of two different views. We give you the ability to look at the patient's data over what we call our timeline view. So if I jump into that, it'll provide me with a graphical representation of what's going on with this patient. It defaults to the last 3 months worth of data for this patient, but I can go in and change and look at other time periods that might be pertinent to me as the provider. And what I get to see here is a representation of what's happening with this patient. So those specialist visits that you were talking about, the hospitalizations, the lab data, all of it sort of in one location where I can look at that data. I can dig into that data if I wanted to. So I can see here they had some medication information. I can click on that. I can see what those medications were when they were added into the system. So really allows me to kind of look around from a time-based perspective to see what's going on with that patient. And then we also present a longitudinal record, so sort of a more common representation, what you might be seeing in your HIE, where I can see longitudinal data on this patient and go look at that same history. So if I wanted to look at all of their medications, for example, I could come in here and see everything that this patient had across time, regardless of source. So it's an aggregated view of all of that data.
Oh, see, that's important.
Yeah, so you're picking up that data from those hospital visits, from the specialists, from other providers, from other facilities like SNFs that are providing data as well. So
Wow.
not your usual set of data, but a more robust, rich experience.
Yeah, and I think that goes back to something that we wanted to do when we're working with clients, is that we really wanted to look at the whole picture of information and not necessarily start. A lot of times people start from this global view, like, well, I want to run reports on this or looking for analytics, in this area, which is good, necessary, and powerful. But a big problem with that is it doesn't necessarily always provide the information needed to improve things. And what we looked at was we started from actually, sitting in the practices, a variety of practices, with organizations, and watching them work, talking to staff, whether it's MAs, front desk, multiple providers, and really figuring out, okay, how does someone interact with information in a practice, and how does that fit into their workflow day to day? Where do they need information? Where do they need it from? And then kind of where are the gaps? And then we started modeling a solution based on those gaps. And really the goal was to look at, especially with ACOs and other organizations, there's a lot of movement towards team-based care, especially for that top 10 or 20% of patients that are often the majority of cost for organizations. And really, what can independent organizations do to have comprehensive information to provide better care to that patient. And how can they do that with the least amount of work, and so that they can essentially work, do what they're supposed to be doing. I don't think anyone in a practice or an ACO really appreciates having to spend staff time and money on chasing paper or playing phone tag to get information out for a patient, or to get information, or to have your care managers spending a lot of time looking for test results and stuff. And
Yeah.
I'm sorry.
Oh, I was agreeing. Yeah.
Yeah, and so that's really what we're looking at, and where we see things moving towards is there's been a lot of product development probably the last decade or so in getting information. You've seen a lot of longitudinal record programs, a lot of health information exchange programs, some stuff built into EMRs, like Care Quality, Commonwealth. And then of course something that's been pushed, especially with meaningful use, is direct messaging. The big problem was that it doesn't seem like there's been a lot of effort on really fitting that into workflow and processes, and helping to make sure that practices can be the most efficient that they can be with the information. And so what we looked at different scenarios. For instance, and this might be another thing we might want to show here in a minute or two, but I don't know if your practice has care management, or you guys work with an external care manager, or even just have patients that have care managers elsewhere. But there are a lot of times when you're trying to manage a very complex patient that has, sees multiple specialists. And it's actually really critical for that care manager to know, okay, so we know they got a referral to go see a nephrologist. Did they actually make the appointment? Did they show up? Do we need to get information back? Did we get the information back? And one thing that we did that you don't see a lot in other tools is actually we didn't just get the clinical information. We also are building real-time scheduling feeds with all of the different practices in a community. So this community, for instance, our pilot community, we built scheduling interfaces with all of the local specialists. And now if a shared patient has an appointment, we can see that they had an appointment, they canceled the appointment, they rescheduled it, or that they never made that appointment. And that helps the care manager or even the provider better reach out to those patients to figure out what's going on, why do they keep rescheduling, or that they had the appointment, so it's time to get them in. And so you don't have these situations where you schedule a follow-up or something like that, and you don't even, the event that was contingent on didn't necessarily happen. I don't know, Vic, if we could show kind of the scheduling view.
Yeah, I'm not sure I have anything staged for that, but let's take a look here.
All right.
I'm gonna grab one of these other patients. And yeah, I don't have anything staged, but basically on the overview tab here, the care team is able to see all of the schedule information for that patient. So they'll be able to see all of the different organizations that patient has been at and had appointments scheduled at, as well as the care team itself, and what we call our visit metrics, which is basically information on utilization. So how many times has this patient been inpatient in the last 6 months or a year? How many times have they been in the ER in the last 6 months or a year? So you can look at that utilization as well in terms of what this patient is using in those inpatient resources.
Oh, that was somebody made something. I think it's for you.
And so here, if you have that patient with heart disease, diabetes, chronic kidney disease, you could see, okay, so they're making their appointments. They went to those appointments. They've been to the ER 3 times this year. And it's that one-stop location where you could really see kind of an overview globally of that patient in real time and at the point of care. And that's something that additionally we noticed help with prepping actually for annual wellness visits for Medicare patients. you now, and for patients in general, you now have this kind of global picture that you can work from and you could prep for, and instead of hopefully having all the information or having to abstract information out of faxes and whatnot, in hopes of having a complete picture and having to expend all that time. And I think that that's something that doesn't get kind of appreciated enough maybe in health IT is how much time practices and providers spend kind of doing this sort of work that really isn't used. It's already been automated or taken care of in a lot of other industries, and that's something that we really looked at improving for organizations. A perfect example I have from kind of my own experience is that and this is something where we could actually have a use case involving payers, is that I recently had to get an MRI. I had to get results from a hospital to my provider. My primary care provider had to put in the prior auth request. Instead of having to, an alternative would have been the provider could actually look right in here. They could see the information from the hospital. They wouldn't need to have called the hospital, put in a request, waited a day or two, like you had said, to have information faxed to them, and then reviewed it. And then even if you think about it more comprehensively, the people doing the review on the payer side could have access to the same information, so that providers aren't spending so much time basically regurgitating or printing out their medical charts to fax to a company to do a prior auth for some kind of test or procedure or a specialist visit. So I think that I think all of us have those sorts of stories, and providers can probably talk about this all day, how much time they spend. And I recently read an article. I think it was a couple of the data itself might have been a couple of years old, but that the average practice, and I don't know how they determine the average practice size, but spent the equivalent an FTE cost of $80,000 a year on FTE, or $80,000 a year on prior auth, paperwork and time. So it's really these areas that we're looking to work with communities, ACOs, payers, to really improve that information flow, so that providers and practices could spend more time on patients. And now when they have that aggregated population level data with their analytics system, or that they get back from payers in the form of claims or cost reports, they have processes and data to improve it, instead of just continually looking at something that might be 6, 8, 12 weeks old.
We actually, Ed, we do have a question that just came in.
Oh, okay, cool.
And this, I think, goes to ACOs of the future. So we know that telehealth and telemedicine's really gotten a jump start with our COVID situation. And the question is, how can this solution that you described work with telehealth?
Yeah, I think that this is actually a perfect solution for telehealth. If you think about, oftentimes it's not always the case that it's a patient's actual primary care provider. Sometimes not even from their practice that's providing that acute care telehealth visit, or it's a external provider because it's some kind of specialty care like telepsychiatry or something like that. And instead of going through the normal paperwork transfer process that you have to do with these providers, like I've seen elsewhere, I've seen, especially in the case of like telepsychiatry and everything, just basically treating it like a normal specialist referral and handling all the paper in the same way. If they're part of your community, like we have set up at Community Health Cloud, they can go in and just access that information. So while that patient is registering for their visit or getting set up, getting their video, getting the application turned on, that information right there is available for them to review. It's also going to be more accurate. It comes from the actual EHRs. I've seen with some telehealth platforms, I've experimented with a few, a lot of times they might rely on actually just patient entered information. So the patient has to quickly, and they're trying to rush through because they just want to get to their visit, entering their meds, their allergies, other conditions that they have, vital, height, weight, instead of having this information, from a validated source. So I think that actually it helps smooth those transitions in and out of telehealth. If the telehealth visit information comes back, then that information is available for the provider, the primary care provider, or someone else treating the patient in a more efficient format to look at. It becomes integrated kind of into that total record for the patient rather than, again, just another PDF or direct email that, ends up in somebody's inbox to process. So I think that, like I said, I think it's actually a perfect accompaniment to telehealth. We've gotten really good at, setting up the video calls, obviously what we're doing right now. And people are comfortable with that. But one issue that really hasn't been resolved with telehealth, especially with external providers to a patient, has been, getting good information to them to help them make better decisions. So I think that that's really where a tool like this can basically make telehealth more effective for the providers on both ends.
It's back to the same mantra of the right data at the right time.
Right, and looking at really, again, just kind of zeroing in at, the different interactions of a patient and the practice staff with information, and making sure that that's there in the most efficient format to process, instead of, just focusing on, getting all the data, because it's actually, in most cases, with the data that's available through integrations, you can get as much data as you want, but the biggest problem has been the application of that data in a way that can help make improvements. If you just kind of collect data, you just really increased your costs. Not really, you haven't done anything necessarily meaningful for outcomes.
And we have another question. You had mentioned about ADT notifications. And can you talk a little bit about how that works with the HIE and what how that information is provided to the individual practices then?
Sure. I think Vic, do we want to show that again and kind of have, I don't know if you probably might be better equipped to handle that one.
Sure. Yeah. So basically, the way we're doing that is we stand in between the HIE and the providers. So we're basically receiving that ADT information from the HIE. So they're aggregating it from all the different sources that's coming in, and then they're streaming it to our health cloud, and then we basically then send that out to whoever needs to have that. So the members of the patient's care team that need to be informed of these events that are occurring. We parse the data to grab the information that's pertinent, present it to them in a way that they can understand it and read it, and also enable things like text notifications. So if clinics want to do that and be able to receive texts to let them know that there was an event that occurred, and they can go then into the portal to look at the details of what happened there. They have that option as well. So really the cloud is serving sort of as their front end to this information. So they're receiving all of this data from the various sources, and it is then doing the job of getting it to the right set of eyes, if you will.
So can I ask by a show of hands, how many participants are now receiving information from an HIE? Allison Smith is. So Allison, let me ask, are you receiving all the information that you'd like to see from an HIE?
I apologize for the noise in the background. I'm doing what everyone else is with kids and everything. So if you hear screaming, my apologies. We are currently, are we receiving all of the information? I think there are pieces that could offer some additional value, but it kind of goes back to what you guys were saying not too long ago, that we're still working through, not the lack of information, but how to use it, how to make the data usable for our providers and our health centers, and not overwhelm them with, additional cool features and applications. So what we're currently getting right now in separate platforms, but we're able to receive ADT information. We're also, have an EHR set up. We also are receiving claims data. What we're not getting across our clinically integrated network is lab data. We've had some conversations with some labs, but that has not been implemented. We're not getting hospital, well, with ADT, we're getting like ED information. Let me be clear about that. We're getting ED information, and we're also able to go into a separate system to see some of the labs and things that are performed in the hospital, to see discharge summaries, but we're not receiving that piece of data automatically into EHRs or into another system for usability. They have to go to the separate platform to actually find that information.
So they're getting the
it's
notification of that discharge, and that's triggering them to go then look for it.
So no, they're not even getting the notification.
Oh, okay.
No. So it's not communicating. They're not being alerted that the discharge has occurred, that this information is now there. They have to, go find that, and they have to go look and see who was recently admitted and discharged from the hospital. So that is something that we're working on with our hospital association, as well as with some of our HIT vendors, but we are not currently receiving that information again automatically. So like I said, it's there. There's a lot that is possible, but in regards to what's currently happening is the notifications about ED visits. Again, we have an EHR set up. Labs, we're not automatically getting labs. That's really kind of it. We've had conversations about remote patient monitoring devices. Again, that's not across the board. Still in conversations about what is possible with our EHR that we have, and all of our health centers that are members of our clinically integrated network agreeing on what we would all go with for standardization. So lots of conversation, but not all of this data currently being fed.
And
I know that was a long answer. I'm sorry.
No, that's helpful. I mean, I would say kind of from a quickest win perspective, I think getting labs and getting a more automated EDP set up, like you're saying here, is probably that's a quick win. I mean, because there's always, for lack of a better term, low-hanging fruit with ER and hospital utilization in a lot of clinical integrated networks. And the thing is, like, if it's not automated, not like pushed to people, it's not going to be used to the extent it needs to be used. And so that's really where, like when Vic was talking about the text notifications, having this right basically in the practice's face and their workflow day to day is the most important thing. And we built tools in there where you can assign it. So if this patient, you see this patient, they've been to the ER 2-3 times in the last couple of weeks, you can actually assign that message right in the application to their care manager, let's say, to get started with that patient and to kind of investigate it and work with them more thoroughly, maybe more than the provider necessarily has time to. But from a technology standpoint, yeah, there's no reason why, like, even hospital labs and practice labs, LabCorp, Quest, those interfaces should be able to be built reasonably quickly and scaled out, because just having to chase down lab information is something that no practice should really have to do. I mean, with the exception of sometimes it's hard to get labs from like the VA, or if you have a patient that spends part of the year somewhere else. I mean, those are going to be always, extra circumstances that might require a little extra effort. But when you're thinking about like a CIN or a community with 1 or 2 hospitals and a couple labs, and some in-practice labs, there's no real reason why any practice should have to chase those down.
And I would think, Allison, too, that by collecting that information from different sources, you still don't have a complete picture. you wouldn't be able to do things like trend.
Yeah, I was going to say, if we could show the lab section, because Allison, something that we did too is we actually built the lab system so that it collects labs across sources. So let's just say hypothetically, you have like a hospital has its lab, its outpatient labs. A practice has, maybe one practice has a lab, or it's a specialist and they do like LC1Cs or something, and you have like a lab core or something. We actually built it out so you could trend and monitor those labs across all those sources. So I'll kick it over to Vic here.
Yeah, so I've gone here into the longitudinal record. I see all of that lab data across all the different sources available to me here. And then I'm able to go into details on any of these labs, look at the specific occurrence of that lab, and then trend that across all of the labs if I wanted to see what's going on with that patient. So basically give you information where your patients may be having this lab work done at multiple different locations to be able to see that, and available from the timeline as well. So if I jump back into the timeline here, I'm able to see that same lab data on the timeline, and I can see when those labs were done visually. I can go into any of those labs and see the details of what was performed there and have that information available to me. And Ed kind of brought this up a little bit about notifying the care manager to let them know that there's something that that they may want to start working on. The way we've set this up, it's available for any clinical data element. So you could do it from that ADT notification, you could do it from a lab result. So for example, if I'm concerned about this patient's white blood count from the CBC, I could send a notification right from here. I could alert the appropriate specialist on their care team, whether that's in my organization or in a different organization. I could let them know that, hey, this is something you might want to take a look at and deal with this. So to give that flexibility down to the data element level is really powerful in that care management, that team-based care.
Yeah, and I think too, just if you think about just the ability to better prepare for visits and things, having everything in this one spot. If you think about like a clinical integrated network that might be a combination of hospitals and independent practices on a variety of different EHRs, and in a lot of especially more densely populated areas, they're competing essentially with payers and for better contracts with payers and employers with other organizations. And as it stands, there is kind of an information disadvantage for independent groups, because if you're a completely enclosed hospital system, let's say, and your health system, you have employed practices, employed specialists, et cetera, some of them even have their own telehealth, and you have everybody on, let's say, Epic, you have much cheaper access to information more quickly than, let's say, you're competing, combination maybe of another hospital with independent practice, a combination of independent and employed practices. And we were, our pilot organization was in that situation where one of the health systems in their community was buying a lot of practices and really building their own network so that they could contract exclusively more with payers and employers. And that organization saw that they were at a competitive disadvantage now. And that's really where we came in with analyzing their workflow, analyzing the gaps, thinking about, well, how does your competitor, have more information? How are they able to work more effectively than you are in your current state? And that's really where the impetus for Community Health Cloud came with, is leveling that playing field for CINs, ACOs, et cetera, that are either completely independent or a combination of independent and employed practices and hospitals, so that they can at least match that efficiency, and then also take advantage of the inherent benefits that you have with independent physician practices from cost standpoints and more physician directed decision making, so that they can.
Okay. So, and I don't know if you guys already covered this or not, so I apologize if this is a question you've already answered. But how, kind of going to the payer contractor piece, is this set up to be able to allow the users to have some capabilities to be able to use the data to have those negotiating conversations? Is there predictive modeling, risk stratification, anything that pulls together that population health view of data?
Yeah, so I can do two parts to that. One, we actually send data from this system to a population health tool that one organization uses. They already had established kind of tool that they were using for reporting, and so instead of reinventing the wheel for them, we basically just more efficiently got them the information that they needed. Our reporting philosophy in the product itself is to fill in gaps that exist within an organization, because a lot of organizations kind of start with reporting and then go down to looking at tools like this to fill in gaps at the point of care. Also, from a payer perspective, actually our pilot client received a very large grant from the largest payer in their state, mostly because they had this tool implemented and the processes that they were able to affect from this tool to be more competitive and efficient in value-based care contracting. So it was actually something they were recognized for, and they were able to be more successful and actually get, like I said, a substantial amount of grant funding to help further improve their efforts. So I think, does anyone else? We'd love to hear from more people here. It's been I know it's a little different of a format than a lot of other webinars, but some other kind of difficult challenges or circumstances that exist in trying to kind of improve information at the point of care for ACOs or practices that are in other organizations.
And if we have time, one more question came in.
Sure.
Talk a little bit about care management or case management at a payer versus in the office.
Yeah, I think that in my experience, having kind of worked with some of them and worked with providers that are working with payer care managers, for instance, they're not necessarily, they're trying to do the same thing as care managers within a practice or within an ACO or something like that, but they don't necessarily have as the breadth of information or as timely of information. They're kind of working with, what the plan has available. And what they can get access to. So I think that, at least in many markets, people have to live with a situation where they may have their own care managers within their organization or practice, and there's also these utilization of care managers within payers. And having this shared platform and this kind of comprehensive record helps kind of provide that additional information that the payer may not have, especially providing it much more quickly with the real-time feeds. But it also helps the patient because you can kind of see where everybody in the team is working, what they're doing, so the patient doesn't have to worry as much about multiple people reaching out to them with different sets of information and making recommendations based on the different sets of information. Because I think everyone's trying to get to the same goal here, but it's confusing for patients to have get that different set of recommendations. And from within here, if somebody's in, like, let's say, a capitated arrangement or some other arrangement with a payer, and the payer has their own utilization managers, like in an HMO, this is something that if it's a shared platform and it's genuinely used to improve outcomes and efficiency, they can see this information much faster than they can get claims from the providers and work from that information. So I think it's really, it actually probably would provide, in some circumstances, more improvement in those circumstances than it may even in circumstances within an ACO that might have, for lack of a better term, duct tape some solutions together now just to kind of get by. That maybe aren't the most efficient, but it kind of gets the job done to a minimum level.
Thank you. I'd like to ask if anybody else has any other questions or any anything they'd like to discuss. One last challenge for a panel. Ed was hoping people would be rude and interrupt each other, but we had a very polite audience. So thank you so much for all the participation and the questions. I think it was a really great discussion, and you know, we'd be welcome the opportunity to speak with you individually if there's things that you see that could benefit your organizations. So, thank you, everyone. Garrett,
Yes, thank you.
I know you've got some housekeeping things you wanted to take care of as well.
Yeah, hey everybody. Yeah, thank you so much, Vic, Ed, Jeanette. This was a very informative session, and I really liked the format. I think that it was really good for us to be able to just talk openly and get some live feedback, and let's keep the discussion going. You know, please continue to submit your questions to the folks at eMed Apps, and the way to do that, one way to do that is if you go to acoexhibithall.com. and you can stop by the eMed Apps virtual exhibit booth that they have there, and you can interact with their team, learn a little bit more about what they're doing, what they're into, and it's really cool. You can interact and just learn a little bit more there. So we encourage you to do that. And then lastly, if you'd like to reach out directly, feel free to do that. We've got, I think on our last slide here, their contact information, and so they'll be happy to answer any questions that you may have. And just as a note, I'm going to be sending out a link to everybody who's registered here with a link to the recording. So you can see that and view that again as many times as you'd like and share it with colleagues. Also, there will be a link to where you can download some of these slides. There's not a lot of them, but it'll have the contact information and some of the other things that were covered. So with all that said, thank you so much again for coming and for spending your time with us this afternoon. I know there's a lot that's fighting for your attention, so we really do appreciate your time. Thank you to the folks at eMed Apps. This is a great presentation, and we hope that you will make some great connections here. So have a great rest of your week. Stay safe and have happy holidays that are coming up. All right. Bye, everybody. Thank you.
Thanks, everyone.
Bye.
Thank you.